So, welcome to NUR203 Pediatric Nursing. My name is Professor Bogart, and I am the lead pediatric professor for pediatric nursing. I have been with Fortis since 2017. As I've mentioned, I did used to be on ground and I did teach pharmacology. I did do community once there. I've helped with med surg, and of course, I taught pediatric nursing when it was on ground. When COVID came, we all went mobile, and then they opened up the online blended program. And of course, I went directly to that because that was my goal, getting my higher level degrees. When I was older, in my 50s, is when I went on for my BSN, MSN, and PhD. So you're never too late, you're never too old. In fact, I felt being older, believe it or not, I understood things better. And actually, my GPA is 4.0 in those higher levels. Now, my first degree when I was 18, 19, and 20 was I just passed my nursing school. I just didn't get it. I was young. So don't think you have to have an A to be a nurse who's going to be amazing. It is what you do with you and asking questions when you get into the field, okay? I mean, I felt like a fish out of water when I went into the hospital, but I asked questions, I got organized, and I just learned, and I was just this thirsty sponge. And I just, through the years, have picked it up. My goal is to teach you how to work with children, how to show you how children are fun, how to work with parents. You're going to hear a lot about that because that is one of the most difficult things with pediatrics. They can be your best friend. They can be your biggest helpers too. So the way I teach is I'm going to start off with just an announcement. For instance, next week, you're going to have your first quiz. It's on this week's information. Okay. So come in, we'll do your quiz first. I will have you come back 8:30 p.m. Eastern time, and then we will do the rest of the class. I first do a PowerPoint, and I send those PowerPoints to you. Now, I do not read off a PowerPoint. I don't believe that me reading it to you gives you any information. I'm going to give you what that means, information on those PowerPoints. When we are done, then we'll do a Kahoots. Now, Kahoots are very important in this class, and I think many of you have already heard it. It is all the concepts that you're going to see or need to know for quizzes and exams and your HESI. I go and look at all the exams and quizzes, and I look at the HESI and all the concepts, and I try to put that information, the ones that I think you really need to understand, on the Kahoots, and then I go back and redo PowerPoints all the time, making sure key information's there for you. So I spend that time. I'm also the one who makes all of your exam study guides, the PowerPoints that you're going to get. And I go through every question that you could possibly have in any class on these things and making sure those concepts are there. Okay. So I work very hard to get you what you need. You just have to read them and look at them and understand them. Okay. At this point in your progression of nursing school, you should not just memorize. You should start understanding why you do things and how you do things and what to look for. Did it work? And we're going to do those as I teach you. I'm going to be teaching it that way. And when I give you Kahoots, I'm not just going to read a question and you answer it. I'm going to tell you the background of that question and why those answers are and why the others aren't. So it again is going to help you understand. It would be great, and I know it's hard with 3 classes, that you come to class at least looking at the information, just to get a brief idea of it. And maybe there's some area you don't understand, so you could come with questions. I don't mind being stopped. I don't get frustrated. I don't get upset. In fact, I really want you to ask questions, and I will answer them to the best of my ability. And if I can't, I'll get back to you. It's basic questions on patient care. And usually after almost 50 years of being a nurse, I can really put 2 and 2 together and figure it out for you. So please stop me. All right. What we're going to do first today is I'm going to do that orientation PowerPoint. You've seen it already earlier. I'm going to go over it quicker because I know you all just saw it in community. I'm going to go over those key things that you need to know for me and how I do things. We all score the same. We all have the same type of thing that way. But there's a couple things that I leave open, like the discussion questions. I'm going to discuss all that so that you know how you could do it for me. So we know that if you have problems in pediatrics, number one, um, you need to have a good computer. When you come to class, make sure it's plugged in and you have the plug. When you are coming in for exams, make sure that you do have those iPhones or whatever you're going to use to do the Zoom on charged also. Those are two things that I see that students forget. If you need anything, I do have a cell phone. It's listed on my Professor Bogart page. It's also, and you can write this down, it's 305 951 8055. Now you can text me or you can call me if it's urgent, okay? If you just email me, I get back to you really quickly to let you know. But if it's something you need to know quickly, please call me or text me and I'll see that a little bit quicker. The other thing is if you can't get a hold of me and it's urgent, I encourage you, and I will never be upset if you have to contact my dean, which is Darlene Brown. And that's her phone number right there. So, and we were good communications back and forth. I worked with her for the last 7 years. It doesn't bother me. My goal is that you get your needs met and you're not stepping on my toes and just I don't get upset because some people might, not me. Okay, always be mindful, be courteous. We know those things as being a nurse. Now, discussion questions. It's already a question here. Well, I've already just looked at them briefly. Make sure your discussion questions has a reference or two on it, okay? You can put information down, but you're not the expert. So where did it come from? Your book is the best reference material. And if there's anything else, put that there. Another thing is these are APA format. So in the body of the paragraphs, you need to put in where did it come from. For instance, if it came from our book, in parentheses, you would put Perry et al., comma, 2023, and the parentheses. And that would be at the end of a sentence within a paragraph. And I will always write that down for you. And that will get you your perfect scores. Now, I was also asked, do you have to wait to put in the responses to your peers? I don't care when you do them. If you want to do them on the weekend, if you want to do them when you do your initial, as long as it's answering another student and a good remark to it, okay? That you've at least spent some, attention to it. And not just you put like, oh, that was a great post. I agree with that. Give me some meat to that potato, okay? So that's what I asked there. So discussion questions, they're all due by Sunday night, but you can do that all together if you need. Now, I'll send messages out on the weekend if I don't see a discussion question or something that's due, usually on Sunday afternoon. I'm like, it's getting too late now. Maybe they forgot. I'll send you a quick reminder. I'm not yelling at you. I'm reminding you. I'm helping you so that you can get the best grades and homeworks you can. Always remember plagiarism. Don't do it. Don't look at those sites. We know that there's a code of ethics and we're professionals. We're professional. Our careers are professional. There are sites that we know are on the computer that students in the past have looked at, copied at, used papers, discussion questions, et cetera, et cetera. I highly recommend you don't go in there and look at them. Okay. Number one is that's cheating. Number two, you're not learning. And then number three, was it good information? Is it accurate information? We have found inaccurate information there. So just, don't go the easy way. I'm giving you everything you need in the PowerPoints and the Kahoots and your study guides. And you have your book to look at, to go more in depth. You've got everything that you need. Now, homework is due on Sunday night, 11:59 p.m. Eastern Time. And I do follow that pretty closely. Now, listen to this closely. If you can't get something in on time for whatever reason, send me a message before it is due. If you send it to me before, I can say, okay, and not deduct on you. All right. Or if it's getting to that 2 weeks, you can't get it to me, you were sick, the kid was sick, the mother's sick, whatever, let me know. I can work with you. But if you don't talk, you don't communicate, I don't know, I can't go back and, let you turn in late homework or whatever. So generally, you're not, talking to me, you're just doing your homework. You need to get it in by Sunday night. If you don't and you miss that, on Monday, I'll send you a message. Please get it in by next Sunday, minus 10% deduction. After that second week, they're no longer available to turn in at all for any reason, unless you've talked to me. So again, communication is key. One thing about attendance, we know that you have to be in on time. 1 minute late is 15 minutes late. The other point of attendance is when you take and you put something in Canvas, they have it set up, the course that you're going to submit. Like this week, you have technology quiz and you have your discussion post. You've got 2 points where you're going into Canvas. And it goes on with your NCLEX question, CJ Sims. If you try to work too far ahead, you're not going to get those 2 points of entry into Canvas. And that's your actual attendance, along with the time that goes there. So be aware of that, even with your other online class. They're going to be sending you all sorts of things when you get 5, 10, 15% late. Now, if you're late because you went to the hospital, your kid went to the hospital, your dog went to the vet emergency, whatever it is, send documentation. If you send documentation, and as soon as you can, after you miss a class or have to leave early or come late, if you do it right then and there, it will be accepted. And even if you get to 20%, they won't take a letter grade off of you. So again, communication, documentation, all right? And that's what that's all about. All of the assignments, I always, every week, will send out like week 1 information. I put the welcome to NUR203 pediatric nursing. That's going to tell you what is due. And in that is also going to have any handouts, your PowerPoint. There's also an Erickson handout there, some theorists, and there's also a vital sign sheet. I'll always send that on the initial announcement. Usually it's week 1, like it's going to be week 2 information, week 3 information, and that's usually out by Sunday. Now, after class tonight, it's usually tonight I will do it. I will be sending out the recordings. I repost all the stuff on those recordings just to make sure you have them. I try to keep you organized. 3 classes, 3 people sending you announcements, you're going to go crazy, right? And I want you to know I don't send out a lot of announcements. And if I do, they're important. Okay, so make sure that you do read them. I will tell you at the beginning of every class, what is going to be due. And as this week, it's just that discussion question, which is due by Sunday. Always go in, look, check your announcements. We're lucky we have them connected to our phones. We can check things easily. If you don't understand an assignment, send me a message. If you need to have an answer right away, because that's when you need to do it, call me, text me, all right? I don't like early mornings, but, text me. I will get back as soon as I can. So we know that there's a bunch of stuff you had to do to get in. Some of you have changed from other classes. Remember, if you had to change from another class to get in here, whatever you had in the first class is wiped out, which means you'll have to do the technology quiz again, etc. And then if you've done a discussion question, just get it in by Sunday night, all of the 3 parts. It's not a problem. I don't do weekly type reviews. What I do is this. I usually come to class early and I'm willing to stay to class after class if you need me. If you need a one-to-one and you need help, let's arrange a time where you can meet with me. I don't keep you an hour or two. Your time is so precious. If you need to understand a concept, let's say 30 minutes at the max. I think after 30 minutes, your mind turns off anyway. So I'll try to get you to that understanding. There are other professors that do have weekly reviews. If you want them, fine. Now, if you are a re-entry student, you must meet with me weekly. So please set up our appointment starting next week, and we could go over what the quiz was, and we could go over things like that, okay? So just send me a message, and I make a whole time schedule up, a calendar, and I fit you in, and we'll get you to understand and get you through pediatrics. It's part of tutoring. So we're an 80-20 class, and that means that 80% of the grades are unit exams, quizzes, and your HESI. The 20% is all of your homework. Now, discussion questions have no open date, so you can do them whenever you want. Be careful making sure every week you submit 2 things. That's what you have to be careful for. Your NCLEX questions, those are open. You can do them whenever. I highly recommend to do them before an exam, but if you're that person who's got to get them done, they're open. The case studies and the CJ Sims only open on time, all right? But you have 2 things that you can work ahead with. I have homework scores turned off. On week 6, I turn them on. That's going to show you how your homework affects your overall grade. I highly suggest anything you turn in homework be that minimum 78, because you don't want homeworks to pull your grade down so that you will fail, okay? On week 8, they're turned off and they don't come on until after the HESI remediation, and that will be your final score. I've already talked about, your exams, quizzes, make sure everything's charged, ready to go. I don't do quizzes on Zoom with an extra device. I leave you on your computers, okay? But I'm going to do a checkup on all of you, and you'll see how that goes next week when we first come on. PGA quizzes, remember, these are on the first part of the class. Your first exam quiz is next week. That'll be the first thing that we do. It is 15 minutes long. It's 10 questions, and it's going to mimic what you see, the concepts in the PowerPoints and the Kahoots. If you listen to me, you listen to the Kahoots, you'll do very well on these quizzes, okay? When you're doing these quizzes, you can only go forward. You can't go back. Make sure if you're doing a quiz, you're on camera. You'll hear me say, let's say someone's camera went off and they're black. I'm going to hear me, first I'm going to chat box you, turn it on, turn it on. If not, I will come over and interrupt everybody to say, hey, could you please turn on your camera? Because if you don't have a camera on, the quiz is a 0. And quizzes are not, you cannot make up for any reason. So if you miss a quiz, you miss a quiz. It's not going to be able to come back. Exams, you come in on a device for Zoom, and then you have your computer for the exam. We're going to do that 360 check. We're going to look at your ears, look at your wrists, all of those sort of things. If you have a whiteboard, please bring it. They're really suggested to have them and not just a piece of paper and a pencil. Now, one thing that can happen in any area, all of a sudden your power goes off, your internet's not there, and your exam stops. What do? Oh my God, I'm going to die. My exam stopped and I was 5 questions to the end. Well, I'm going to let you know that the exams never are lost. We can always pull them up and have you start where you ended up. We can get that done. So don't ever be afraid of that. You can't upload it right away. Don't be afraid. Your exam never disappears. So you need to immediately, when this happens, send me a message. That's why you have my cell phone. That's why you can also email me also. And that tells me that this has happened. I can actually look at quizzes and exams and see every time you touched a key. And if you went off the site to somewhere else, I can see all of that. So your date stamp and time stamp of that email or text is, correlating to when that computer went off. I can validate it, and then we could get you started again. So if you can't be online because what's happening, just let me know. Anybody with accommodations, let me know, and let me know as soon as possible. There are some students who like to take exams on campus. I have to know, you need to tell me, and then the person who's proctoring needs to send me an email, and it has to be done 3 days before the exam. I don't mind that happening. I work with many of the campuses. Just I need to know soon enough to be able to do it. And it is a 72-hour notice. Hopefully, it will be right around class time. That was the one thing that I do request if you can. If you can't make an exam, something happens, you ended up in the ER, or you were in an accident or whatever, please, first thing you do, let me know. Send me a text, send me a message. That way, you're not going to get a minus 10% on your exam. If you wait till after the exam where I'm contacting you, you can do the exam within 1 week, but I will start you with a minus 10%, or you'll start the exam with a 90. I don't want to do that. Just communicate, communicate, communicate. I think you're hearing this whole thing. Communicate. So that's what I just said about exams. Quizzes we know are in Canvas. Your quiz 1 is already set up, ready to go. Any problems, and let me know. Now, HESIs. HESIs are now all given on campuses. Last quarter, every was on there. Nobody did a virtual sort of website for it. So they're all being done on campus. I don't have those schedules. You have to find out HESIs when they are on your campus, because they do it according to needs and rooms and faculty who can proctor. Okay. I do want you to know that overall, my HESI mean scores are above 900. I have many students that get 99.99. I've got all the information there, all the concepts there. Again, if you do what I'm telling you to do, make sure you study those Kahoots. I will send you, you have all your exam handouts, your study guides. And for the HESI, I've got 2 100-question Kahoots, again, re-going over concepts. And on the Saturday before the HESI, I do an open forum, get you thinking about growth and development and thinking about disease entities and what to look for, et cetera, et cetera. And I've been told that it really does help. Remediation, you're going to see that posted. That will be in your announcements. Always have your ID. And again, anything you let me know. Keeping yourself organized, as I said, you're going to see that in the announcements. We've already been over that. NCLEX questions, make sure you submit them properly. Now, your first NCLEX question is not under pediatrics. It's under growth and development. And it's all of the areas from adolescent to infant, okay? If you see a 0 in your NCLEX questions, it's telling you you didn't do the right one. And I will let you get it in by that next Sunday without a deduction. All right. Because I know a lot of you will do it and you've already submitted something, but you need to submit the proper thing. So be careful, because I do check that. And again, make sure you print it and upload it. If you didn't submit it correct, you'll get a 0 also. But I will send you instructions in case you don't know how. All right. So you see a 0, don't go, oh my God, I got a 0. No, Just resubmit it by that next Sunday, and then you could get your full credit, no deduction, okay? And as I said, those NCLEX questions, in the minimum you should get is a 78. You got plenty of time to redo them. Now, there are some evolved courses, the HESI courses. It's the assignment exam, practice exam. You must do them through Canvas, and the score should automatically go over into the Canvas shell. If it doesn't, let me know. I know how to look them up. All right, so I can make sure you get your grade. Usually 1 or 2 students every quarter, I will see that grades didn't come through, okay? And let me know, just let me know that it wasn't there. CJ Sims, as I said, they can't be completed before they're assigned. So when the open date is when they are. I cannot change it. They are open for 2 weeks. So just to let you know that. I have been told by students who have gotten 1100 and 1200 on the HESIs that one of the things they did do is the CJ Sims, they just didn't fill in the right answers. They actually went and said, well, I don't know the name of that med. I don't know what this is. Went back, looked it up, and understood it as they went forward. And it really helped them to start to think. Okay, so it is one of the ways of doing case studies and to look at it and to understand a lot better. And there's 6 of them. There is a project, and it's due week 8, and it's 3 sections. It is 6% of your entire homework grade. So it is very heavily weighed. One section is an APA paper, 250 words. And what you need to do is there any diagnosis that a child that you know, or you, or your children, or your neighbor, your sister, whatever, somebody you know has something and you want to know more about it? Those are actually the ones that I find are easier on you because it doesn't seem like just busy work getting it done. So the one thing about this assignment, when you want a diagnosis, send it to me because I don't want to have 10 on ADHD. Give me something else. Give me something I want to know about. Every quarter, some student or 2 or 3 send me something that I've never heard of before. And I love learning. So teach me. And then tell me why you wanted to know that diagnosis and know more. So the first thing is a paper. What is it? Tell me what the diagnosis is. ADHD, what is it? And then you're going to need your references on the bottom. Make sure you cite in the paragraph. The second part is on your modules, and it's a like 10-page assessment. A lot of it's just circling. It's not as big as it is, but the last 2 pages are on theorists, and it's on NANDA diagnoses. And that's very heavily weighed on these papers. And then the third part is a PowerPoint, a pamphlet, or a poster board where you teach me something. And it could be a child with juvenile diabetes, how to give a sub-Q injection, where to give it, how to rotate sites, how to manage the insulin, how to store it. Could be asthma, how to give an aerosol, what to do with them. What is CPT, ADHD, how to do organization, giving me checklist skills, a blackboard on how they, would check, keep them organized, whatever it is. And that PowerPoint, 5-6 slides, doesn't have to be big. Put references on the end. When you're doing this, you don't have to have the whole thing done to send it to me. Send it to me in pieces, and I'll grade it piece by piece. Usually students about after week 4, after your exam, it's a great time to do at least the starting paper. Send it to me. I'll score it. I will show you areas that you could change, and then you can send it in to get your perfect grade, okay? So I do work with you back and forth with it. Now, the last week of it, it's hard to do that with as many students as I have. So if you do it earlier, I can do really a thorough job with you so that you can really understand, because many of you will be going on for your BSN, MSN. If you're crazy like me, and maybe a PhD. But what is a BSN? It's all papers. It's an MSN. It's all papers. So you have to learn APA. I can help you and show you. Because I remember I was deers in a headlight when I first went back to school. I didn't know I needed an office and my computer to go to school. I'm like, why do I need an office? I'm not opening a business. I'm in school. Office, Microsoft Office, Word document, PowerPoint. I didn't know what that meant. So I've come a long way since the beginning of my education. There's always a rubric, follow it. Make sure that you use, good scholarly information. And then, the one thing that we do as professors, and I know Dr. Brown does too, we look at this education process as if you didn't turn it in a homework or you were late, that could be a medication or a treatment you didn't do, or you did it late. Or if something happens and you didn't tell me, that could be a patient that something happened and you didn't communicate with the charge nurse or the physician. So that's what all of these things here mean, okay? And then this is one student's, what she told the professor about how she got 1145 on a HESI. Now, many of you are going to say that I'll never do that 99.99. You know how many students every quarter that are just sitting there at that 78 on HESI day get a 99.99? There are many of them because they listened and they did what I told them to do to pass their HESIs, okay? So don't think you can't be that person because any one of you could get that. And, who doesn't want to get a 99.99 on HESI and go, whoop, whoop, I did it, right? Then it's like, I'm complete now. So anyway, what she did is like the CJ Sims, as I said, go really through them, really look at them, understand them, and the NCLEX questions too. Because remember, what do you take to be an RN? You take an NCLEX. So those questions are so important. Okay. So I went over that pretty quick for you because you've already been there and I've given you all the things, that I are familiar with me. Anybody with any questions about anything and homework and submissions or stuff like that? Okie dokie. So were you all able to open up the PowerPoint and the one that I attached? Okay. There are times where attachments don't open or handouts that I give. Do not be afraid to let me know because if you can't open it, somebody else can't. And then I will just send it as a message in Canvas to make and ensure that you all get it. So please, you don't get something, I want you to have it. So healthcare and children. Now, the federal government has these major health um, things that they want to do, improve on all different disparities, whether they're the young, the old, the homeless, mental health, all of these things. And they have focused on certain things. I remember when I first started and going back to school was Healthy People 2010. And there were different goals, but they all go on the health about a child. You will see as you go further in your education process, you're going to use some of these type of things, whether it's mental health, nutrition, maybe weight, oral health, and you might do a paper on them, all because it came from Healthy People. So this is a great place to go to look at stuff. Big problems in children, obesity, type 2 diabetes. Just think about all the fast food that we eat today. It used to be mom stayed home and cooked meals and they're always nutritious, right? Well, those days are far gone. We have to have two people working in order to make ends meet, and we do know those sort of things. Um, Childhood injuries. Kids are always getting injured. I call the toddlers the dive bomb kids. They love to jump off of couches onto another couch and land on the floor and hit their heads, right? Because they have no filter. They don't know. And then, of course, the adolescents, they're like, oh, we're old enough now. And they do these things that they shouldn't, and they are getting injuries. And they're unintentional injuries, but it happens. And the biggest, highest level of where the injuries occur are actually a motor vehicle, whether you're in the motor vehicle or underneath the motor vehicle. I've seen many toddlers ran over by cars, and I've seen good outcomes and not so good outcomes. So it is real. The car thing is very real. That's why I think they've put in backup cameras on everything now. And I've watched that development as I saw children ran over by cars. So I've seen changes to help improve it. And these are usually neighbors, aunts, uncles, mothers, fathers that do it. It's like not like they tried, okay? And it's just happenstance. It did happen. We know violence, whether it's bullying or otherwise. We know vaping is a big thing that's going around. And then you think children don't have mental health problems. I've seen some serious mental health problems in children, and we need to take them seriously. Now, the United States, we would figure, would be having the least amount of infant deaths or infant mortality. We're not. We lag behind many, many other nations. We need to do more stuff to catch up, to keep our infants alive. An infant is first year of life. They say the neonatal is the first 28 days of life, okay? And then after that, all the way up to 1 year is an infant. We know that many more things can be done. What is the biggest determinant about it? It's actually their weight. Is it low birth weight or very low birth weight? I've seen infants born at 450 grams. That's less than a pound. And these children make it, but you can't imagine the struggle they've gone through. Intraventricular hemorrhages because their brains and vessels are so fragile and they bleed in their brains. And then retinopathy because of oxygen and breathing. And then problems with their lungs as they grow up. So, I mean, to have a low birth weight, yeah, it's really a long struggle. And they're always fighting with sepsis. They're always getting an infection somehow. Childhood mortality, they say that the death rates for children as they get older, excuse me, as they get older, it's going to be less than as infants. We know as they get into more of the older preschoolers and the child school age, that's where they starting to think. They know better. They've done it already. They've already been hurt. They're not going to do it. But then they get to be adolescents. What happens when you're an adolescent? You're the big boy now. You're the big girl, right? You know better. And then you start doing these things because you have a little bit more freedom of your time, and then injuries, homicides, and then suicide is actually big in adolescence. And as we go next week, 2 weeks from now, we'll talk about the adolescents. They're all about body image and all about identity. And they struggle with it and go into depressions, many of them. And suicide is a big thing, okay? Increased mortality, these are those children at risk. Homeless, and homeless is real. It is happening. Living in poverty, of course, if they're born low with low birth weight, and then if that child who's chronic illness, sickle cells, cystic fibrosis, cardiac disease, anything like that, and then foreign born, adopted, because we don't know what all conditions they could be with, and then children in daycare. Oh, what do children in daycare do all day long? They swap toys, right? So they're swapping spit and germs all day long. It's a good and bad thing. You want them to get the germs, to get the antigens and immune bodies against it, but you don't want them that sick all the time. These are some things, that we look at in children and mortality. They find the guns, suffocation. I mean, South Florida, swimming. How many children did I see come in that were drowned? And then you'll see permanent brain damage. And it does happen even to the bestest of families. It just does. Taking pots off the stove. My brother had a big burn down his arm, and it was there for life, a lot of the scarring. And of course, getting into somebody's medications. I think the biggest thing they like to eat is their vitamins. They love them. But if it's Tylenol, guess what? That's a bad deal because Tylenol can hurt their livers. So, pediatrics, family centered, right? What does family centered care mean? Well, we know family is the constant in a child's life. This is what they know. especially the younger kids. They've never been anywhere else. They just know what the family does, the way the family culture is, their routines, the way they speak, talk, dress. So family is the only constant. Now, what is a family? Whatever they say. There's so many different definitions. When my grandson was born, and you'll hear all about Christian this semester. He's always here. In fact, he's in the other room right now. And family for a while with him was him, his mother, me, and my husband. And it was a great family. And then, thank goodness, when he was about 2 years old, she met a wonderful man, and now she's married and has her own place. That's her family. But family is whatever, to women, to men, grandma, grandpa, adopted, they're all different. Doesn't matter, whatever they say. I think we're the psychologist, the pediatric nurse, because you're going to take care of children, you're going to be taking care of family. And, I've said it a couple times already, but remember, family are your ears and eyes to your child. And if you make them important, they're going to feel important and they're going to help you. And not only have they helped you, they're helping the child because they're learning how to take care of them. One of the things in children is they're afraid of needles, aren't they? What do we do for the first every time they go to the doctor's office? They get shots, right? Injections, immunizations. And they're just, oh my God, more immunizations. So we try what we call atraumatic care. And it's comfort care. And it's, giving care with the least amount of pain and stress that we can. And that's what we look for in many ways. It could be a program that I developed down here in South Florida called Huggies. Help us give great injections efficiently and safely. H period, U period, G period. You look it up on Google, you'll see it there. And it's all about holding your children for injections because they have less stress, pain, and fear because they're in mommy's arms before the injection. And after the injection is done, mommy's still hugging them. So it's something that I developed and I gave it a name to. So it decreases all that stress. So social, culture, family, as I said, could be anything. And all of those are some of your names of them. We know that families, there's some good ones that can help you and some that we have to teach more. Again, understanding, the mother, the father, the grandma, who's the ones that we can help that child. When we take care of another person as a nurse, we need to think about the other person. Who are they? Socially, culturally, religiously, because we have to respect that. We don't have to understand, believe anything. We just have to respect and give them the time that they need as long as it does not interfere with their care. And I've done crazy things to do that. And the families do absolutely appreciate it. We know that, all of this influence comes from a lot of different places. Race, culture, ethnicity, I mean, all of these things. Religion, when they do their prayers, or what food do they eat, how do they dress, all of these things make a difference. So, what do you think this is? A frequent health problem of migrant children and adolescents in the United States. What do you think? When you're in doubt, you always go to the bottom and just click it off. And it's actually the rate of tuberculosis, okay? And we know that a lot of migrant children, etc., um, have this, they come and they have TB. They're not tested like many of the children in the United States are with the health care that's provided. So, cultural health beliefs. Again, special foods, clothes, medicines. We need to be aware of it. And what does that mean? Well, if you're ordering a meal tray for a person, what if they're vegetarian and you send them up a piece of steak or a sausage? That's being offensive. So, asking, is there any special needs in your diet? If you don't know, ask. Parents are so grateful when you ask and you don't assume. Okay, they'd rather answer a lot of questions because they know then you're taking really good care of their child. Okay, their clothes. One of the things is clothes. And then as we go and do treatments, how we keep and maintain dignity, not undressing them too far, What about those cultures that have the headdresses and all over them, these cloaks? And, they don't want their whole body hanging out. This is part against, and it's offensive to them. Also, a male can't take care of some of these females as a nurse. So understanding that is a good thing. Another thing is giving them an ability to do their prayers, whether it's 6 times a day, or other different things. I've done all different crazy things, allowing parents to do for their child and helping them. They feel, and remember, they're emotionally, they feel they've done everything. When you feel better, you're going to do better, right? And then one of the things that I have saw when I moved down here, I used to live in very country New York. I came down here as a registered nurse, and I found working there's what causes an illness. Well, I had some friends that were Dominican, and they believed that if you got rained on and went inside and your hair got wet, you're going to be sick. Or if you had wet hair and went to bed or didn't dry it before going outside, you're going to be sick. Another thing I've heard is, especially abuelas, grandmas, that you have to wear socks in the house if there's tile on the floor because their feet will get cold and are going to be sick. And I will tell the grandma, take the socks off when they have a fever. Why? Because the cool will pull the fever out of the body and get them feeling better. And when the fevers are down, they'll eat and drink more. And what does the grandma want? They want to feed the child. So if we can explain things to these people to understand, it helps with a child's care. We know there's all different voodoos, witchcrafts, evil spirits. It's just part of some of the beliefs to understand. Another religious belief and the things that I have worked with is you get children and infants, brand new infants, sick, especially when I worked in the cardiac intensive care unit. You get a brand new infant in with a really severe congenital heart defect. Parents want these children baptized, and giving that parent that opportunity to do it. Absolutely do it. What about that child who's Jehovah Witness? Now, when we have premature infants, newborn infants, you don't start making your own blood cells, your own red blood cells, to what, 4 to 6 months. So you're left with mommies. But if you're in a hospital, what are we doing every day? We're taking a little blood to monitor their electrolytes and their CBC and their white counts. And their blood starts getting lower and lower. And then they start getting symptomatic. They start getting apneas and bradycardia. And that's symptomatic when your hemoglobin hematocrit are too low. So we have to give blood to a Jehovah Witness child. Well, these parents will not sign a blood consent. So they go to the risk manager, they get a court order, and we can give blood. Now, that doesn't mean you're going to take that bag of blood, come up, hang it up in front of those parents, and let that parent watch it. They feel, and this is what I have determined what they think. I may be wrong, but what I think is that they feel that the body from that person of the blood goes into their child, and they don't want that to happen. So I don't ever give blood in front of Jehovah Witness parents to a child. Now, I've done it on the night shift. It's easy. You send them home. But on the day shift, I'd send them out of a room, and this is the way I used to do it. I would take the blood, I would make sure it's all going, and cover all the tubing with blankets so they can't see the blood. And I'd go on the side of the bed and look and make sure the IV site was good. And when it was done, I'd put them out of the room and I would clean it all up. They would never see an IV bag, they would never see the blood, and they would always be grateful and thankful. They know the child needs it, but now I've respected them, haven't I? And that's part of respect that you earn from parents. Again, nurses are there to help. They're always going to ask you, so what would you do? What would you do if it was your child? And it's a very hard situation. If it's never happened to you, do you really know what you should do? You can just give them options, and if you don't know, say, I just don't know what I would do. Honesty is the biggest thing. So, leading cause of death among African American boys ages 15 to 19. Let me tell you, this is a time of injuries. It's the firearms. Because now they think they're big enough. They think they can, play with them because they're big enough. And, they've gone to the shooting range with dad before. And that's when accidents happen. So, looking at growth and development. Now, one of the hardest parts of pediatrics is growth and development. They don't, it's something that you need to know certain things about. Um, but you're not going to see crazy amounts of information on it on the HESI. You're not going to see crazy amounts of it on your NCLEX. This is something that we test through our quizzes and through exam one. Now, what do you need to know about growth and development? You're going to get cahoots from me and you're going to hear me certain things you need to know. And today we're going to go over certain things. But remember, next week is infants, toddlers, and your preschoolers. So I'll go into it more in depth, okay? We know growth and development is all interrelated, simultaneous, and ongoing. For instance, your gross motor skills. Now, gross motor is get up and go, go, go. It's movement. What does a baby do first? First thing they can control is their neck. They can hold their head up, and that's by 3 months. By 6 months, they're turning from front to back and back to front. They're rolling over. By 8 months, they should sit unsupported. By 9 months, they're starting to pull themselves up and they're starting to creep and crawl. And by 1 year, they should be taking steps or attempting to take steps. That's just gross motor. So those are some things that you need to know. And why do you need to know that? Well, what if I was 6 months old and I couldn't lift my head and control my neck yet? Supposed to be by 3 months. That means something's wrong. So what we would do is what we call early intervention. Find out if there's some physiologic reason why, or we're going to institute either physical, speech, or occupational therapy, whichever they need, okay? So really important that we know these key little things. Couple definitions for you to look at, okay? So one of the things about growth and development, just like the simultaneous thing, is what we call sequential trend. That means you lift your head before you roll over, before you get on your knees, before you sit down, you crawl, and you walk, okay? There's a certain way. Now, it doesn't mean that a child lifts their head up first and then they roll over completely by 5 months, because usually it's just the belly or their abdomen to their back by 5 months, and then their back to their belly by 6 months. Some kids go right to the rolling over, by 5 months. And as long as they're moving forward in the pattern, they're doing good, okay? All children are different. There are children who are walking by 7 months. There are children who don't walk till 15 months. Does it mean one's delayed? As long as they're moving forward in the sequence, they're not delayed. There's just some kids that are quicker than the others. Growth and development, metabolism. I sent you that vital signs sheet to show you the differences in vital signs. I mean, adults are easy. It's 60 to 100, 12 to 20 respirations, right? Easy to remember that. Well, talk about a new infant. Their heart rate is 140 to 160. Normal at sleep, resting. And what is their respiratory rate? 40 to 60. Now, as they get older, those numbers come down. And the blood pressure at birth, normal, 60 over 40, gets bigger as they get older. So why do we need to know that stuff? Well, don't you need to know if they're dehydrated, in pain? Don't you need to know if they're, you need to give digoxin? Because we give infants digoxin. It's one of the biggest drugs we give to cardiac children. And we do need to count it, apical pulse, right? So you need to know what these heart rate stuff are. At birth, children come out, they're wet, they get cold, they need to be rubbed off and put underneath a warmer right away. As they get older, they can hold their fever in. They're not going to get cooled off like that quick as they do at birth because they're getting more of the fatty adipose tissue, right? So temperature regulation, it does change as they get older. Sleep and rest, we know infants sleep a lot. As they get older, they don't. And the one thing is the biggest thing on growth, development, and cognition is nutrition, nutrition, nutrition. Children must eat properly. How do you figure out if they're eating? How would you know if the infant's eating enough? Well, what do we do every visit with any child, any age? We take a height and a weight, and we could see their weight going up. Now, a newborn infant born at 7 pounds by 6 months should weigh double that, 14. Well, what if they're 10 pounds and not 14? Well, they're not getting nutrition. You're not putting fuel in the tank. They're not getting the gas they need for cognition and for growth and development, and they're probably delayed. So what would we do? Well, we would look at what do they eat daily and maybe increase the calorie count in formula or even breast milk, okay? We can do that for both of them, and that would catch them up. By 1 year, they should triple their weight. And this is why we look at those things, because without the gas in the tank, these children, growth development and cognition, it's not going to be where we need it to be. We know children are all different. You have easy kids, difficult kids, it all depends on multifactorial. Now, the hardest part, I think, about this first exam and pediatrics are the theorists. And here's a list of them. The first 4 we use a lot. Fowler's is just a global, what did I say about understanding about spirituality or culture? You don't have to believe in it. You just have to give them the opportunity to practice what they like. And let's go into the other ones. Well, Freud, all about psychosexual. And if you could see oral, it's all about what infants do. They suck, swallow, and breathe, right? How do they soothe themselves? Pacifier or a finger? Oral, they explore the world in their mouths. That's why it's called oral. Anal, potty training. They're toddlers, ages 1 to 3. Phallic, preschoolers, they're understanding boys and girls and differences. And then it goes up to your adolescence. Now, that's when the hormones kick in and the genital stage comes in, right? The sexuality. That's Freud, all about psychosexual. Erickson is the most tested of all of them on your NCLEX, HESI, exams. This is what you're going to see. And I'm going to go over this again next week when we get into the different age groups, but I'm just giving you the introduction today. So trust versus mistrust. This is your first year infant. Why would an infant trust you? Well, I cry, somebody comes, picks me up, burps me, changes me, and feeds me. I'm trusting. What would be that child who mistrusts? That's the child that's not being picked up, not being fed, not being changed, being ignored, and they cry themselves back to sleep. And that can happen in many type of dysfunctional families, right? Either dysfunctional or maybe drugs or alcohol or whatever. Things can happen, and that's mistrust. Now, it goes up into the toddlers, autonomy versus shame and doubt. Well, what is autonomy? It's all about me, right? It's all about me, mine. And these toddlers love to explore. They like to get into everything. They're in that exploration stage, and you can't keep them out of the cupboards or underneath anything. And that's what toddlers do. But what is that shame and doubt? That's mommy saying, oh, no, get off the couch. You can't jump over there. You're going to hurt yourself. Oh, no, you can't ride over there. Watch that. Oh, let me watch that. Let me take care of this. And not allowing this toddler to do things for himself. That's the shame and doubt. And then it goes onwards, and we'll go into those more, but I just wanted to hit you with those two. Now, cognitive is how you think. Let me explain. An infant doesn't know anything at birth. They just know at birth, they come out, they cry, and somebody usually will put something in their mouth, and whether it is a breast or whether it's a pacifier or a finger, and they suck and it soothes them. That's all they know at first. Then they start with mommy with a little rattle. And initially, there is what we call fine motor development, which is all about fingers. And the first thing is a reflex grasp. So they don't know they're doing it. They just, by reflex, they grab the rattle. And then all of a sudden, that infant moves. And oh, look, it makes a noise. So now they take the rattle and they shake it because they know a noise will be made. They're thinking now they've learned. They didn't know what that rattle did before that. Then it goes into their mouth and they start sucking and chewing on it. Like, oh, I like that too. So do you see how they went from not even knowing a grasp? They did it reflex. They made a noise and they're learning. And now the next time you give them that rattle, maybe they're going to be able just to voluntary grasp it. It's called a palmar grasp because it's the palm of the hand. And they grasp it and they just shake it. And you'll see children become very smart. And as they go more into thinking, it goes into pre-operational, which is thinking and creative and using broomsticks for airplanes, and trees have leaves. And it's just all of these, the way that they think, that magical thinking. And then it's school age. And I think probably school age and your adolescence are your hardest to understand. But school age is concrete. I've seen it, touched it, felt it. I know what it is. I can mimic it. That's what they can do. They can't think outside of that yet. Now, formal is that teenager who can fight his way out of a paper bag by thinking and being creative and getting mom and dad to do what they want to do. No, you're not going out next week because you didn't listen to me and you didn't da, 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 da. And no, you can't go out Friday night to the movies with your friends. Well, they know I'm going to take out the garbage, make my bed, put my laundry away, and get an A on an exam. And mom's going to say, okay, you've been good. You know what to do. Because they thought. They never were showed that before. They just said, I can figure this out. And that's formal. They can figure. Okay. We'll go over that again. So cognitive development, we know that they start out with cooing and crying, and then they know how to communicate from there, banging on the cribs, etc. And again, this is all about thinking and getting their needs met. Now, Kohlberg is all about morality. This is right and wrong and a consequence for either. It's punishment and reward. That's what they know. Kohlberg. Just think right and wrong. Now, what do kids do from the moment they wake up? Don't they just get up and play? Go out, they get their eat, whatever, and then they get their toys, they're put on the floor and they're into everything and play. Well, we have names for these sort of plays, okay? We have they play together, social affective, sense pleasure. That's sand, that's water, that's mud, that's clay, that's gooey, that's putting them in a high chair and let them mash their potatoes with their fingers and stuff like that. That's sense. Skill would be building something. Unoccupied play, behavior, they're alone, don't want to. Dramatic or pretend play. Sometimes we can use dramatic play to find out what's gone on in the hospital that's got them scared. There's different plays for that. One of the things, sensorimotor development. What does that mean? Well, playing helps the child cognitively learn, just like that rattle and the shaking in the mouth. They like all those things. Well, sensorimotor is sense, is touch, feel. Oral is mouth. Motor is moving it. And all of these movements and tasting and touching and feeling are all getting them to learn. And it really opens their mind and they start putting all the pieces together and they become more aware of themselves. I mean, this little kid got into purple paint. They get a little bit too, I don't know if they get the purple out of that child after that play, but the kid had fun and was, enjoyed all of that. Very creative with it. Now you need to know the names of these plays, okay? We have an onlooker play, which means you're looking at somebody else play. They're playing and you're watching. Solitary play, you're in the corner playing by yourself. Toddlers love parallel play. Remember, toddlers are autonomous. I, me, mine, I'm not sharing with you. So they're next to each other, playing with their own toys, not sharing, but they're playing next to each other. Parallel play. Associative play is two or more children together playing, but there's no goal. There's not like a board game where you'd win checkers, or it's not like you got together and made a castle or a house together. There's no end goal. Associative, two or three children playing together, sharing toys. Cooperative play is two or three children playing together with a goal, whether it's building a sandcastle, building a house, building a racetrack, whatever it is, that is cooperative play. So those are the plays you need to know. Now, toys are really important for the growth, development, and cognitive growth of these children. It helps them move, it uses their muscles, makes them start looking for things. And we know that tummy time with mommy, it brings them together. And we know that all of that pushing and pulling and rolling all helps with them getting stronger and stronger. Now, assessing developmental assessment. Now, children are all different. All ages are different. One of the things about children is you can't just go in there, take a blood pressure cuff, put it on their arm, and push the button. It's not going to happen. So, first of all, you should never be above a child. I would have them in bed or on the stretcher when I worked the last 10 years in the emergency room. I'd be on a chair below them. I mean, I'm a big girl. I could scare them, right? So I would get below them. And then I would open up a conversation developmentally appropriate for them. Whether I'd say, oh, is that a Batman shirt you have on? Oh, I like Batman. What does Batman do? Or maybe I'll start with a toddler. Where's your ears? Where's your nose? Preschoolers. So are you in school yet? Do you like school? Now we've had a little bit of rapport. So I've gotten below them. I've developmentally appropriate to them, open that up. Now we're going to do things. Let them touch, let them feel the equipment, and then let them help you. And when you take a little bit of time with children like that, they're going to help you because now you've made it fun and you're not threatening. And in the long run, you save time by spending just a little bit of time with them. Taking a child who has disabilities, like this picture to the left, looks like that little girl has cerebral palsy. There are ways to assess them, and there are ways to assess children that are nonverbal. So there are tools and checklists and whatnot. Every hospital has different stuff. Children can be born with all different things. They can be born with hip dysplasia, club feet. They could be born without an arm, a finger, a leg, a bone, or they could have some sort of genetic syndrome. Downs is the first one you think of, right? There's Prader-Willi, there's DeGeorge, there's Pierre Robin, and I could go on and on and on. There's so many things that can happen. We know that a lot of times genetics can cause these things. And one of the things that is encouraged, especially after a child is born to a parent and they want another one, to encourage them to get some genetic testing. Sometimes, it's not just genetics that causes the problem. It could be the ingestion of something. It could be the mother, alcohol, cocaine, drugs, whatever, or it could be that they were exposed to rubella or CMV. That's why pregnant women shouldn't be changing litter boxes, right? CMV is a big thing there. Or it could be due to the physical thing, or even something metabolic. And that's why we do those little circles at birth called the PKU, right? making sure their metabolic system's working. So in growth and development, something that we need to be teaching parents. Parents think that this kid did this at 8 months, but your kid's not doing it yet. Like, is that a problem? Again, making sure parents know that this is all absolutely normal for them. Parents, when the kid's not born with certain things, they feel guilty. Making sure that you give them that time to express themselves. Especially I've had worked a lot in the cardiac intensive care unit, and these mothers come in and they've just had a baby, so they're hormonal, and they've got an infant with a really severe congenital heart defect, and they're feeling like they did something wrong. And the first thing I'll tell them, I said, it's not that Tylenol or that glass of wine you had. This is just something that happened during growth and development, fetal development that occurred, and they're still going to feel guilty. But you saying that makes more difference than you'll ever know. And then as they're growing and we're seeing that they need help, again, making sure as nurses, we say to the doc, hey, this child's not speaking the way it should. How about if we start some speech therapy? And the doctor's always going to say it's not a problem. So communication, um, talking about your medical records and HIPAA. Remember, yeah, they're just like adults, but what's the one thing about pediatrics? At age 18, a child can sign himself into a hospital, into an ER. They sign their own consents. We've got to ask that child permission to talk to their parents if they're there, because now they're the adult. Okay, be aware of that. That's a big thing. What about emancipated minors? What about a minor who comes in with their own baby? So there's a lot of different variances with HIPAA and consents, etc., in pediatrics that is different than adults. Now you get a child in and you have a parents and you need to get a history on them. Now, sometimes you have a parent that's going to sit there and tell you about an 8-year-old child, everything that happened from birth. Well, birth, I just want to know how they were born and if they were in the, stayed in the hospital after birth and how long, or if there's any medical conditions. What I want to know is what is going on this admission, what has happened. And that's what we call redirecting the focus. Again, there are some parents that you can touch and hug, and there's some parents that you cannot touch and you can't look them directly in the eyes. This is important to remember, and you'll figure that out. You'll see they'll be standoffish, some of them, because I'm a toucher. So I had to learn who I could and who I couldn't. Again, remember to listen. Very important. One of the biggest things that I think I was good at was being empathetic. Can you imagine having an infant come into the ER after a week of being sick, and they've already gone to the doctor twice, they've been to urgent care, and now they're in the ER going, I don't know what to do. And this mother's been working, has other children, and you could see she's exhausted. Telling that mother, you've done a great job. You must be exhausted. Let me help you. Just saying that you recognize that they're exhausted and that they've done a good job, a parent's going to feel so much better. Okay. And you're going to see the shoulders drop. Like, okay, I can do this. We'll get this kid through it. Again, with talking with kids, there's all things you can do. Like I said, there's play where you can talk about their cute shirts or their little lidded sneakers, or I always had stickers in my pocket, SpongeBob, and I would have Spider-Man and princesses and whatever else I needed. And I would be giving stickers out to children, and they love that. Again, always communicating, big thing is go on the developmental level of the child. You'll have 2-year-old and 6-year-old, you're going to treat them both different, and you can play a lot of games with them. If you have a room of people, I know that I worked in an emergency room where I could have 5, 6 people come in with one kid. Who's going to tell me what's going on? Because sometimes everybody wants to talk at once. They all, have that little piece of that kid at some time, and they just want to, they want the best for the child. So again, tell me, who do I speak to, and tell me what's going on now. As I said, birth history briefly, we don't need anything big about it. Of course, dietary. What do they eat? What don't they eat? Of course, any previous surgeries, injuries, you always want to know allergies. Immunizations are big in children, making sure that their immunizations are up to date. Because an upper respiratory infection could be pertussis, and that could be a big deal unless they're immunized. Allergies and last medications, Tylenol and Motrin. When do they get it? And the one thing with ibuprofen and infants, you cannot give ibuprofen till they're 6 months old. There's something to do with platelet coagulopathy and bleeding that they can't handle it before 6 months old. So only acetaminophen for the first 6 months. And then, of course, if they're being admitted, you want to know this child's habits. What is their favorite pacifier, or the favorite bottle they use, or the favorite blanket, or doll, or jammies, or toy? Because sometimes parents have to step out of the room, and you need to be able to go in there and, soothe that child if they're crying. Getting a health history, especially when they get older, sexual histories, you're going to have a lot of adolescents. They're not going to want to talk to you. They're not going to want to say anything in front of a parent, because the mother will hit them, be mad, will ground them for life, right? So you can ask parents to leave the room with an adolescent and get a history. And you do not have to tell that parent what they said, unless it's something that's going to hurt themselves, the child, or others, okay? And that's some ways that we do get some information, and we do that occasionally. Understanding older kids. I would always ask the older kids, so how you doing at school? It tells me a lot. Are they all C's? What's your favorite subject? Who's your favorite teacher? All those things. It helps. Parent-child relationships. I used to be, when I worked in the emergency room, I could tell a lot about a parent and a child and the control of that child by what I would find when I walked into the room. These children will be placed on a stretcher. They'd go to the otoscope, take those little black caps, throw them all over the room, or into the drawers, pull out alcohol pads and gauzes, right? Everywhere. And the mother's just sitting there watching TV or on the phone. And you're like, oh, we got really good control of this child. And it does happen. And that means I would spend extra time if the child need medications or something to make sure that they knew how to give it to the child. It seems like there was no control there at all, right? Again, looking at food, what do they eat? Any cultural things. They don't like meat, they don't like cows, they don't like pigs. What is it? Just let me know. Also, we know that there are some children and cultures that are all vegetarian, and some of them could be anemic. So if that's due to the dietary restriction, what would we do as a nurse? Well, we know that they are vegetarian, and we can see their blood levels are anemic. Call in a nutritional consult. Get dietitian up there, right? Find out what could they add to increase so that they could get more iron in their foods in order to get those hemoglobin hematocrit elevated. Now, don't expect to do a head-to-toe assessment on any child ever. It's not going to happen. Usually you go in and do a focused. If the kid is not breathing well, you're going to go right to listen to the lungs if you can. If you have a small child comfortable or asleep in a parent's arms, you're going to be listening to the breath sounds and heart sounds because they're quiet then, because you're not going to be able to hear it later on, right? So again, head to toe, that's adults. You can do it. Not with children. You get what you can when you can get it, okay? And again, doing anything on a child below them, open rapport, developmentally appropriate, build up that trust, and then you're prepared. Let them touch that blood pressure cuff. Let them push that button on the machine. And then that gets a really good relationship, and the kid's not going to be afraid of you, which is what you want. So which approach would be best to ensure a positive response from a toddler? What did I tell you the first thing you need to do?
Eye level.
Yes, right. You need to get down on their level. Absolutely. Because if you're above, you're really threatening. So when you are looking at the child again, kids are afraid. We know it. And again, getting them ready, including parents when you need to, and always developmentally appropriate. Now, remember, as we're doing assessments and looking at height and weight and pulses and temperature, remember the age of the child. Then you'll know, is it abnormal or not, right? They say that you need to do an apical pulse on a child up to age 2, and then you can do a radial pulse. Blood pressures, I'm going to go on as we go on and show you where I do them. But looking at them, I think the one big thing in pediatrics is well appearing and sick appearing. Kids are both, one or the other. You don't ever see them in between. A sick kid looks sick, and a kid that's not sick at the moment or the fever's down at the moment, they're not going to look sick. But when the kid's just sitting there not moving, you know something's wrong. Of course, any assessment, you're going to look at a little bit of everything. No, abdomens are usually a little bit distended and soft. So again, it's that inspection, auscultation, palpation. One of the things that we don't think about is, why are we looking for an anus in a child, especially the newborn? It's because some are born without one. In maternity, you're taught to do a rectal temperature at birth, right? So you can properly measure the temperature. Well, it's also to make sure there's an anus, okay? I never saw one in my whole career, which is quite amazing, I think, because I've seen a lot of many other stuff. Again, looking at their backs, and this is telling us clues. Little skin tags could be renal things. Little dimples in the back above the buttocks could be a problem with the closure. I mean, all of these things are important little clues to what we need to do to take care of these children. And then the neurological thing, making sure they're moving everything and reflexes work. Again, we're looking for a neurostatus. One thing we do a lot on young children is head circumference and abdominal circumference, and we do it for many reasons. Newborn ICU, you're going to do a head and abdominal circumference every shift. And we're looking, is their brain getting too much fluid on that brain, right? That'd be a hydrocephalus. You measure the head, we can catch it soon. Abdominal circumference, we're looking at the tolerance to the feed. If they're eating, the abdominal circumference, they maintain the same. It's getting bigger, means the food's not going down. It means that you need to look at why not. Now, taking a height. Now, I worked a lot in the ER the last 10 years of my career, and I was in the triage area a lot. I like triage. I had to sit there and figure out what the kids have and send them to the proper area in the ER. So I thought it was fun. Well, one of the hardest parts actually is to take a kid about this age, this little girl here, and try to get a height. They think that big board's going to come down and bop them on the head and hurt them. So I would get underneath it first and put it down and say, so what number do you see? I said, okay, your turn. Let's see what number you get. Here, you hold it. You tell me when it touches your head. They're not afraid anymore. And I got an accurate height on them, which is exactly what they need, because they do not like that coming down. But make it a game, make it fun. Blood pressure cuffs come from 00 to extra large adults. So which one do you choose? Well, you got to figure it out as you work in pediatrics, which one will work the best, okay? I actually, on my toddlers and preschoolers, like D for my blood pressures. I put them on the lower leg because I can hold the leg and I can distract them with other things and I can get a blood pressure and it doesn't hurt. I mean, if I put it up on my upper arm, it hurts me. And I know the kids don't like it either. So you put it down there, it's atraumatic, right? It's not as painful as the upper arm. So that's why I do that. And then the last chapter for today, there's 5 of them, is pain, pain in children. Probably one of the things that bothered me the most was the inadequate pain management. Many nurses are afraid to treat pain. Believe it or not, one of the safest opioids to use in children is morphine. It's been around forever, and we know it well, and we know how to give it well. So what happens with pain is the nurse doesn't, give it on time, waits too long in between, doesn't evaluate that it worked, and then didn't do anything with the pain. Did they do any distractions for them to take their mind off of the pain? Now, there's a couple pain scales that we use. We use faces, which we call it Long-Baker faces, and that starts at age 3, preschooler, age 3 is faces. And then numeric, according to your book, 0 to 10, 0's no pain, 10's the worst in the world, and that starts, according to the book, at age 8. Now, this is your type of faces scale. One of the things about children in pain, unlike adults, they don't over exaggerate. They're going to point to a number, and that's what they really are. Ask an adult how much their pain is, and they're going to tell you a 12 or a 20, right? Children don't do that. They'll point to that 7 to 9 or to that 6 because that you're asking a question. They're going to answer it, and they will tell you. So faces starts at age 3. Now, numeric, as I said, age 8. Now, the one that we use for infants and toddlers, so ages 0 up to age 3, is called FLAC. We also use this for any age child that is nonverbal. I've used it on cerebral palsy children that are teenagers, and it works well. And what does it evaluate? Well, the F is the facial expressions. Are they grimacing? Can you see the crunkles in their forehead, right? Their leg movement. Is it moving? Is it like back and forth? Or the activity, are they laying straight and don't want to move because they hurt so bad? And of course, are they crying? And then can you console them? You have an infant who's crying, who's grimacing, whose legs are moving, and you can't console them. That child's in severe pain somewhere. And then we got to figure out where it's at. So you need to know these: numeric, faces, and FLAC. Those are your 3, and you will see them. Remember, faces starts at 3, and it's FLAC up to age 3 and nonverbal. So acute pain could be due to anything. I think probably one of the things that hurts kids most is ear aches, ear infections, believe it or not. And as soon as they come in, I give them, they tell me, well, this is the ear that hurts. I run out and give them either Tylenol or ibuprofen and get something into them right away. And you're going to see a difference in a child just with ibuprofen or acetaminophen. It does help. We know that they fall down, they hurt themselves. As they get older, the braces, etc. There's all different reasons. Teething in infants. And there's chronic, reoccurrent, persistent pain. We have sickle cell kids. We have cardiac kids. We have kids that, can be in chronic pain. And just know, an older kid who's always in pain, can you imagine how they would feel? That's not going to be your happy-go-lucky kid. That's going to be a kid who's going to have more emotional issues because they are always in pain, and it'll affect every aspect of their life. As I said, any kid that can't talk, non-verbal, there's all sorts of checklists. Another thing to think about is cultural differences. I know that I've had parents come in, like usually it's a dad, comes in with a son. Let's say there's a broken wrist and they need a cast. And the doctor says to give him some morphine before the cast. And the father says, fine, he's going to suck it up. Don't worry, he doesn't need it. Because his culture believes that he doesn't need to admit he's in pain. And I will say, it's going to hurt. He's going to need something. Just think about it. And then I'll get the physician back in there to say, listen, this is something that he needs. Some cultures still won't do it, but it's usually got to man up, be a man. You don't need anything. And that does happen. And I've seen it quite a few times. So with pain, again, you can give medicine, you can give the morphine. And then if they're still in pain 2 hours later, you do have acetaminophen or ibuprofen, usually that you can give also. But also we have something called distraction. Distraction can be done many ways. All right, you have a kid who's in pain, you've given him something, you've repositioned them, headed the bed up, maybe you got an ice pack or a heat pack, or you gave them a pillow for their belly because it hurts. Now distract them. Oh, give them, an iPad with Roboblocks on it. Well, they don't care about their pain anymore, do they? Because now they have something to distract their mind. Give them crayons, give them card games, put on a movie, put on music. All of these things do really work with these kids. Some of the premature kids, like that little infant that's called kangaroo care, it's on her bare chest. Some of these premature infants are in their isolates and they're moving and they're wiggling, and you can see they're so upset, they can't get comfortable. Mommy comes in, we put them on her chest, and that kid calms down. The heart rate goes down, their respiratory rate goes down, and they go to sleep. And you can see it really does help. And one of the biggest non-pharmacological things to do is a pacifier. A pacifier with some little bit of sugar water or sucrose on it, okay? My grandson, at age 1, at 1 month old, had a circumcision. It was really tight. He had to get it done. He had it done with a pacifier with just the sugar water on it. Now you're saying, does that work? Well, in my research for my project for my PhD dissertation, there were some Harvard neuropsychologists or physiologists that studied the effects of morphine for pain and a pacifier with sugar. Do you know there was no difference in pain relief from the morphine or the pacifier? So, what is the safest for an infant? It's the pacifier. So, self soother, pacifier, the best thing for younger children that can't control themselves. Because again, oral is satisfying, they calm themselves down. As I said, you have acetaminophen, you have ibuprofen, you have the opioids. As they get older, they can have those PCA pumps for surgery, right? They can push their own buttons like adults. And yes, we do use it for older kids having big surgeries that are going to be in a lot of pain. The epidural, that's when all the back sort of stuff. We use all of that stuff in adults, we can use in children. But again, it has to be appropriate for their age. This little girl here is smiling because she's got that white blob on her anticube and she's going to get her blood drawn. And why is she smiling? Because it's a numbing cream. And she knows when they come to draw her blood, they stick a needle in, and guess what? They don't feel the needle, it doesn't hurt, and she's happy, right? So, again, we're going to be using these sort of things for pain control, okay? Pain is everywhere, as I said, from teething, circumcisions, to surgeries, etc. So using the pain scales, figuring it out, and then distracting them, using proper medications, or just positioning can help. So, which of the following is an important factor for consideration in understanding the pain experience in children? I'll ask you, do children always tell you when they're in pain? They don't want to be shot with a needle, do they? Or sometimes they don't like medicine. They're not going to tell you they have pain. They're not going to admit it because they feel that, maybe the pain is they've done something wrong, or they don't want that needle, or they don't want that medicine, and they're just afraid. So again, it's that nurse to make it not so bad. So how are you guys doing right now? I have one Cahoots run through and you're going to be done early tonight. Is that what you'd like? It's like 34 questions and we'll be done with it.
Let's stay till 10.
Just about, yeah. All right. Have you ever played Cahoots before? Now, the one thing I like about Cahoots is, you know, if you've looked at the information before you come, that's the first time you've seen it. Then you've heard me talk about it, and now I'm testing you on it. So again, this is 3 times you revisited the same information. At least it's twice. And that repetition is going to help you learn. All right, let's get going. A lot of these things you're going to see again next week also, because again, it's just that repetition that I want you to see these concepts. From a worldwide perspective, infant mortality in the United States. So when I talked about the United States and in the first year of life, how many infants died as compared to the other parts of the world, where are we? Are we higher? Are we lower? More kids die? Less kids die? And it's the highest of the other developed nations, which means we are behind many other nations in our infant mortality. It's getting better, but we've got more way to go. So the leading cause of death from unintentional injuries in children is, I mentioned this. Children, they don't think, they have no filters, they're too young, and things happen. But the one that's the big constant with this is we have motor vehicles, is the big, big, big things. Whether they're young in the car seats being put the wrong way, or they're that adolescent who now is driving, all those fatalities there. Which statement is most descriptive of pediatric family-centered care? What is family-centered care, huh? So we know that the family is that only constant they have. As a child gets older, they get more from their friends and neighbors, etc. But the constant that's always there is the family. It's that constant is family. The major cause of death for children older than 1 year is. And we call it unintentional injuries, right? So children older than 1, they're out there doing things, they're climbing up dressers, TVs falling over on them. I've had that happen. They're falling out of balconies. It's what we call unintentional injuries. It happens because these children don't know better. The nurse caring for the child in pain understands that distraction, what? It has to be developmentally appropriate to refocus them. You wouldn't go into an adolescent and put on cartoons to distract them. You would do something different, right? Maybe give them the iPad to play a game. So again, it has to be appropriate for that child that you're working with, or it's not going to work. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? And 2 or 3 children are all playing together. Same toys, they're all playing, but there is no goal. They just keep playing. And that's called associative play, okay? Parallel is toddlers next to each other playing, not sharing, because they don't share. Associative, 2 to 3 more children playing together, same toys, but not with a goal. Cooperative is 2 to 3 children playing together, a goal, whether it's playing a board game, somebody wins, or building a tent or a fort or a racetrack. They have a goal in the end, okay? You need to know the types of play. Which statement best describes the process of critical thinking? Isn't that something you learned in nursing orientation, that you have to learn how to critical think? Well, you guys do it every day. What am I going to have for dinner? Do I have it at home? Do I need to pick it up? Do I have the money to get it? All of those things are part of critical thinking. It's purposeful and it's goal directed. You know what you want and you're going to go get it. And that's your goal, whether it's making dinner or getting to school. What is probably the single most important influence on growth at all stages of development? Growth, development, cognition, nutrition, nutrition, nutrition. If you don't put gas in the tank, they're not going to grow and they're not going to be aware. Frequent developmental assessments are important for which reason? And why do I need if a child rolls over, or if they can walk, or if they can lift their head? Why do I need to even look at that? It's because it does identify delays. And then what do I do if there's delays? Children are so resilient, they catch up quick. So, number one, figuring out, is there a pathophysiological reason why they're not there? Or do they just need physical occupation, speech therapy? Kids catch up so quick, they're resilient. Which function of play is a major component of play at all ages? Why did I tell you they play? I mean, I can tell you it's all of them, but it's one that's all of them. It's sensorimotor activity, which is creative, it has intellectual development, and it is social. It's all about the touch, the mouth, the movement. It's figuring all of those things out, okay? Which does all the other. 3 children playing a board game would be an example of what type of play? And it is cooperative play. Yes, very good. The head to tail direction of growth is referred to as head to tail. And cephalic is a head, right? So cephalocaudal, that means you lift your head first, and then you turn over, and then you crawl, and then you creep, and you sit. This is all head to tail, and the tail means walking, and this is all cephalocaudal, head to tail. It's the first year of life. What is the single most important factor to consider when communicating with children? So always, before you start talking to a child, the first thing you need to do is get on their level and so they can understand you and not be threatened. Very good. What 2-year-old pain assessment tool should you nurse use? Remember, we have FLAC, FACES, numeric are the three that we use. And this is FLAC. From 0 to 3, it's FLAC. At 3 years old, it turns into FACES. And then at 8 years old, it is numeric. At 6 months, an infant's birth weight should do what? And the reason why we need to know these things is, are they getting too much nutrition, not enough? These are things that we'll look at closely. And yes, they double it at 6 months and they triple it at 1 year. The first expected fine motor developmental milestone for an infant begins with, and remember, F is fingers, fine, fingers. Gross is G, get up and go movement. Okay, so F is fingers. I mentioned it's that rattle, and they first grab it. Why do they grab it? And it's because it's a reflex palmar grasp, and then it's voluntary. And then as they get older, it becomes a pincer grasp, which is that picking up Cheerios off the high chair like that, but they start crude, like a smush into the face. And then it becomes that very fine one in the end. So as they get 6, 7 months, it's a crude pincer grasp, and they're holding on to the rattle, etc. And as they get more older, it's going to be more of the neat pincer grasp, and then it's going to be putting things into containers and then building a block of 2 by age 1. And that's in your reading for next week, too. An 8-month-old infant should be expected to perform which fine motor skill? With the fingers. What do you think an 8-month-old should do by now? Well, an 8-month-old should be able to sit unsupported. Well, that I know about that. Fine motor skills. They should be able to grab that rattle, and it's that crude sort of smush up, sort of pincer grasp, getting close to that. When it gets to putting stuff into containers, that's at 11 months, and the block of 2 is at 1 year old. The natural physical developmental sequence that most children follow is, this is all about gross motor. What do they do first? What do they do by the end of a year? So they lift their head by 3 months. They roll completely over by 6 months. By 6, 7 months, they're up on their knees, crawling, and then 8 months sitting unsupported. Then they stand up about 9 months and they cruise and they hold on to a couch and move around. And then they start attempting to take steps by 1 year old. They're either walking or attempting it. Which behavior indicates that an infant has developed object permanence? You know, children and infants are smarter than you think. This talks about a concept where you show a child a toy or something and they see it, and then you put it out of sight. They're going to go looking for it because they know it's going to be there somewhere. It's like you put it in the toy box. The kid's going to know to go grab it. So object permanence means it's permanently in their brain that they know it's there. And I'm going to go find that object. That's what that means. Okay. Object permanent. In general, an infant should triple their birth weight at how many months of age? And that's at 1 year, 12 months. Very good. Perform a head to toe assessment on a toddler. Most important to consider before beginning the examination. Make sure it's on that child's developmental stage. First, you get down to eye level or below, right? Then you're going to base it on their age after that you've broken the ice and they'll trust you, okay? Infants, older infants and toddlers are very difficult to examine. They're afraid of strangers. It's that stranger danger. So if you do these things, the kid's going to be happier and the parent's going to be happier too, because they're not screaming when they see you. According to Piaget, toddlers are in the blank developmental stage. This is all about cognition. Piaget is all about thinking. And this is about how we took that toddler, that infant, and they took a reflex grasp and then they heard the noise. It's sensory and motor. It's all about touching, feeling, in the mouth, moving things. That's what toddlers are with Piaget. That's actually, it's like the 2 to 7 age they talk about sensory or motor, moving it. All the other two in the bottom, the yellow and green, are Erickson, more psychosocial, and then formal operations is your adolescent toddler. They can fight their way out of a paper bag and make you do what they want. Which intervention helps a hospitalized toddler feel a sense of control? I think the hardest age group to have in a hospital are toddlers. They're afraid, and um, there are certain things we can do to have them be less fearful and feel like they know what's coming. And it's number one, parents at the bedside. You can't require them, but the best thing is parents to stay with the child. That's the biggest thing. But besides that, try to get them on the same routine and the same foods if they can take the same foods. Bath time the same time, nap time the same time. Try to keep it consistent, and that child will feel a lot better. So why toddlers are hard to take on vacation, because they're not on any routine. All children reach developmental milestones at the same age? Yes or no? Every kid walks the same, sits the same, crawls the same? Absolutely not. They're all different. They're all special. They're all unique. And as long as they're moving directly in the right way, the right sequential way, they're doing good. Immunizations for a 4-month-old infant. What action should the nurse take to provide atraumatic care for an infant? How do you decrease the pain in an infant? How did I tell you? I mean, first of all, I'd like to have the parents hold the child, right? A Huggies type thing. But the biggest thing of all is to give them that pacifier with a little bit of that sugar water on it. And it works so well. Which of the following immunizations can be administered to a newborn? I believe you learned this one in OB. It's usually in the hospital before they're discharged. On occasion, they do it at the first doctor visit, and it's usually insurance authorization, believe it or not, that they have to do it then. Now, there are a lot of immunizations infants get as you do your reading for next week. There's a double page of them. Okay, you're going to be going over the ones you need to know. Hep B is one of them. It is the first that they do give. The normal heart rate for an infant is, and it's 140 to 160. Yes, it is. 80 is a little bit too low, and 40 to 90, you're going to be doing CPR in an infant. What is the preferred site to give an injection to an infant? Do you remember your pharmacology? And if you're going to do an injection like this picture is doing, I'm going to go in there and be upset with you because that infant's going to pull that needle right out of that thigh there. And I've seen needle scratches across legs because of that. And it's called the vastus lateralis. They don't go and do deltoid till they're older, okay? So vastus lateralis is what they're doing for newborns up to when they're up and walking, and then later on it's the deltoid. The death of an infant under 1 year old with no known cause is called what? And next week, we're going to go over causes, possible causes for this. I mean, the one thing I can tell you, the one thing that can prevent it is breastfeeding. A child who is breastfed has a decreased incidence of SIDS death. This is something that the hospital that I work with down here very closely since the 90s have been doing a lot of research and collecting data on. And they found back to sleep, putting a child on their back to go to sleep has decreased SIDS deaths exponentially. A Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why did she do that? Why didn't she want to look at the nurse? What is that all about? And then I'll tell you, if you do not understand, always ask. And it is respect. It's absolute respect for the nurse that they don't look at them. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. Why is he saying that? What's interesting about this and this culture, it's very much like young children. They feel that if they've done something wrong, they hit their brother, they didn't do well on their math test, and they got hurt or they're sick, they think they're being punished by God because they didn't do a right thing. And we're going to learn about that more next week. But in this culture, it's an absolute health belief. It's very common for them to feel that way. Which term refers to times in an individual's life when he or she is more susceptible to positive or negative influences. Again, this is part of those definitions on the PowerPoint. And it's called the sensitive period, okay? It's just one of those terms you just got to go and just look at those definitions again. What is characteristic of the pre-operational stage of cognitive development? So cognitive development, this is Piaget. This is what he talks about. Pre-operational is ages 2 to 7, they say. And why is it concrete? Remember, concrete you can see, touch, and feel. That means you've seen it before. So now you can use it because you've seen it used before. That's concrete, all right? The rest are too old for them. The logical, that's your adolescence. And then it goes, those other ones are very close. But concrete is that age where they've seen it, touched it, feel it, they've seen it before, and now they can use that as part of their thinking. and last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Preschoolers are ages 3 to 6. And remember, morality is right and wrong and a consequence. So actions are determined as good or bad in terms of their consequences. And remember, preschoolers don't know how to manipulate. Should I do that bad thing because I really want it? They mostly do right or wrong because it's reward or punishment. And let's see how we did today. Number 3, Hannah. Good job, Hannah. Number 2, whoop, whoop, Haley. Good job, Haley. Number 1, Peds nurse. Yes, I like Peds nurses. Libby and Kirst. So this is the end of class for today. As I said, we would be out early. Now, anybody who has any questions, of course, remember, I'm always here. I can meet with anyone. Anybody who's not good at dosage calculation, I am a person who can teach you easily. I'm known for it. I do give you examples of exam 1, 2, and 3 type questions that I'll give you practice worksheets to work on. Anyone who misses any math questions, you should not. I can help you. I've taken students who cannot do math and turned them into all 5 questions correct. So if you need that help, reach out to me and we'll make an appointment and we'll get you done. There is one several dosage calculation recordings on my YouTube site. Remember, I do have a YouTube site. It is Professor Bogart, Pediatric Nursing, and it's got 2.5 years of all sorts of recordings there. You're going to get this recording later on tonight within the hour, so you always get it pretty quick, but there's always resources for you there. I will be sending out a calculation. Send me a message that you want the worksheets, and I'll send you the worksheets and a recording, and then we can meet when we're done. Just watch that initial recording, and I'm telling you, your mind will think easier. It is not ratio proportion. I don't do it, but I can show you how to pick the numbers out that you need. Okay, so I'll make it easier for you. Any questions, guys? Been a
Are you
great
going to
class.
be sending Kahoot?
Yes, absolutely. I always send the
Perfect.
Kahoot with the recording. Absolutely.
Okay.
You're going to get the recording, the Kahoots, and I'm going to send the PowerPoint and the handouts again, just so you have everything to be sure. Okay.
Thank you so
Any other
much.
questions? Oh, you're welcome. Nice meeting you all.